Hello and welcome to the Head and Neck Connect, a supportive space created by the Head and Neck Cancer Alliance, especially for caregivers of head and neck cancer patients and survivors. I'm Melissa Cook, a patient resource navigator and speech pathologist for the Alliance. Today's video shares practical tips for the head and neck cancer journey, with insights on surgery, radiation, chemotherapy, and a direct caregiver perspective. There's a lot to cover, so let's get started. Please welcome Dr. Beverly Garber, a nurse practitioner at UC Davis, where her clinical practice emphasizes comprehensive head and neck cancer care. Beyond her clinical work, she is a key board member and friend of the Head and Neck Cancer Alliance, and she has been instrumental in conceptualizing and launching the Head and Neck Connect support series, demonstrating her leadership and commitment to this community. I'm sure you'll find her passion for improving patient care, supporting survivorship, and helping patients and caregivers alike will be incredibly valuable to us all.
Hello, my name is Beverly Garber, and I'm a nurse practitioner at UC Davis Health in Sacramento, California, with the Department of Otolaryngology, Head and Neck Surgery, and I'm happy to be here today to review some surgical care tips for caregivers. First, I'd like to mention this quote, "Doctors diagnose, nurses heal, and caregivers make sense of it all," as I find this to be very true as a clinician and seeing caregivers and my patients interact. The caregivers really are the ones that put all the pieces together for the patient and their loved one in order to get the best care they deserve. When it comes to surgical treatment, there are many phases in the care of the patient with head and neck cancer. The first we consider the preoperative phase, and this is typically preparing for the surgery, having the consultations with the appropriate providers, having testing done, including labs, cardiac checks, and making sure all the instructions are clear. But it also actually begins the discharge planning process as well. In nursing, we like to say discharge starts on admission. And I think that's really important to keep in mind as a caregiver, to start thinking about what happens when my loved one comes home and how do we start planning ahead for that as early as possible. The next phase is what we call the perioperative phase. This is during the inpatient care setting, so typically from surgery until discharge. This includes the education and support that the patient will need in the hospital if they are in for an extended stay. And the caregiver is an important role during this phase. Another set of ears to listen to the instructions, give guidance to the nursing staff to help understand what the loved one needs, as well as being a support person during an otherwise challenging time frame, as the patient typically is uncomfortable, sleep is disturbed because of multiple interruptions, and they're not in their own comfortable setting. Next is post-op. We consider this to be also after surgery, but really the focus is also when they're discharged home and they have follow-up appointments related to their surgery. So this is the surgical-related care, such as wound care. It could be needs related to diet, nutrition, as well as speech considerations. But I think the important part at this phase is also to think about transitions in the patient's treatment. Is this patient going to need chemotherapy after surgery or radiation after surgery? What are the follow-up appointments that are needed in a timely manner? And the caregiver is hugely impactful in this role to help advocate. And then the next phase tends to be the longest phase, which is the surveillance and survivorship period. This is the follow-up care to ensure that there's no recurrence, and then really highlights the functional outcomes of the patient. And again, caregivers are seeing their loved one every day and can give the clinicians a lot of insight as to how they're doing. Are they as functionally well as they might communicate that they are to us as clinicians in their visit? Are there actually concerns related to their emotional and physical health? Are they losing weight? Are they having pain that they don't want to communicate or tell us about? Or do they continue to have risk factors that put them at risk for having another cancer? So our caregivers are the eyes and ears in the real world every day and can really help give us feedback as a surgical specialty in our surveillance and survivorship monitoring for the patient. As I previously said, our caregivers are an extra set of eyes, ears, but also hands. The surgical role of the caregiver is really impactful, and unfortunately a lot of caregivers end up playing a role they were either not educated or ever planning to take. They become nurses, they become wound care specialists, they become dietitians. So the caregiver plays many, many hats in the care of their loved one and our patients. And we really honor that because they're taking on a whole set of skills that they're not necessarily prepared for and quickly have to adopt. So the first part of this is the education and preparation, not only for the patient, but for the whole family or the community that the patient is within. And we always want to encourage the patient, but their caregiver, to take notes and ask questions. There's never a dumb question, and there's always room for more questions and clarification. So while our timing is often limited based on busy clinics, having notes written down with specific questions, even if you think they'll be addressed, I think having them checked off the list is hugely helpful. I know in my visits with patients, I love seeing a list of questions because most of the time it's a question we'll address together anyway, but it really does help me steer the visit to be focused on what the family, the caregiver, and the patient really need to know, not just what I want them to know. Also, reading and gathering materials to prepare for the surgery or for what's needed after the surgery. As always, a caveat is making sure it's a reputable resource. If it's online, message boards and discussion boards can certainly be helpful, but you have to keep in mind the limitations in the information that you're receiving, and it's not generalizable. And so it can be all too specific and not applicable to your loved one. The caregiver also is very important with helping us manage and monitor symptoms, as well as navigate resources. So it's important as a caregiver that you also understand what your loved one will be going through and understanding what their expected symptoms or unexpected symptoms might be after surgery, and then also knowing how to navigate the resources available to you, whether it's at your loved one's institution or within your community. Of course, the caregiver plays a supportive role, but they also really help to ensure the safety of their loved one. So again, that's where discharge starts at admission. Are there stairs in your home? Is there a complex location that the patient will need to stay in order to make sure they're monitored and kept away from any potential injuries or sites that could become infected? This could include even something as simple as their beloved pet wanting to, snuggle up next to them, but there's a wound that needs to be protected. So some of these things don't necessarily come to our minds as a surgical specialty that the loved one and the family member might have greater insight to in terms of the patient's environment at home. And sometimes that means not being at home if it's not safe enough during the initial healing phase, or having home health come in to help make sure that the care that the patient needs is addressed, and then also gives the caregiver a little bit of support so that they know exactly what to do. And then last, advocacy for the patient, but also for yourself as the caregiver is really important. I greatly value caregivers and families who speak up for their loved one and make sure that their loved one is getting what they perceive as the best care possible, asking for support and resources. So I think it's very important to feel confident in your role and speaking up and advocating for what you either feel the patient might need, or you've heard might be a valuable resource for the patient, or if there's ever a need for any clarification or second opinions, that's always encouraged, so that the patient truly does feel confident in their care, and that includes you as the caregiver. So that helps me transition to the needs of the caregiver. And it's really important to understand that the role of the caregiver does not have a defined time period. There's never really an off the clock or you've signed out for the day with this job or this role. So it's critical that any help that is offered from others that you consider accepting. So I would encourage you to adopt a yes, thank you response anytime an offer to help is given. There are also opportunities for what we call respite care, which really does mean to take a break away from a situation, whether it's the caregiving role in this case, and there are opportunities to research sites in your area. This link is included so that you can evaluate what respite care opportunities or resources you might have, and understanding the role of respite care to help make sure the environment for the patient or your loved one, as well as for yourself, continues to be positive and safe. If we go back to those surgical treatment phases, In review, again, the preoperative care phase is a good time to start thinking about your loved one's code status. And this references if there's an emergency or the need for life-saving therapy, what would your loved one want to have done for them? This could include limitations on feeding tubes or breathing tubes or CPR. This could mean decisions about their care if they are not available or aware or awake enough to make decisions for their own care. So having these documents established or at least discussed upon is really important before surgery, even in a minor surgery, just so that it's documented and there's clear communication between the patient's goals and wishes when they are not able to communicate that themselves. This includes the goals of care. So when it comes to surgery, it's very important that the patient and their caregiver expresses what their goal of having surgery is. That could be pain relief, that could be management of a wound, that could be curing my cancer, for example. So I think it's important to know it could be those very broad general, but it also could mean a patient saying, whatever is done surgically, their most important thing is that they get to go home and care for themselves, or they are able to maintain their swallowing or their voice, because some of these goals may not be managed with surgery. And it's important for the surgical team to really understand what those goals are and how those goals might change. And then also educate the patient and the caregiver on the limitations of surgery related to the goals. Again, as we discussed, you do want to start thinking about the discharge needs, even at the time of surgical planning. Is the home safe enough for the patient to come home to? Is there enough care? Are you, as the caregiver, able or feeling confident in your ability to support your loved one because of your own limitations that might be unsafe for you to be able to provide the care that's needed immediately after surgery. So skilled nursing facilities and home health nursing are wonderful opportunities to consider as a transition phase. Including all of the providers within the care team. This includes primary care and a cardiologist or a pulmonologist, really any specialist that's actively involved in the care of your loved one and helping plan the surgical care so there's less complications is very, very important. And that's another role for advocacy. Medication reconciliation. A lot of times the surgical team is getting documents with the patient's history that may be incomplete. And so having a list of the medications is very helpful for them to plan the surgical care that's needed, because sometimes there's some timing of medications that need to be adjusted in order to make that surgery safe, particularly things like bleeding medications for bleeding disorders or blood thinners because of a history of a stroke or a cardiac event. So always things to advocate for your loved one. Dental concerns is an interesting one that might not be thought of initially when you're thinking of the surgical care for the patient. And this is really related to what the patient might need after their surgery, specifically radiation. And hopefully the providers are communicating that. But I think understanding if the surgical site is related to anywhere near the mouth or the throat, that might be something where dental needs are important to help manage the timeliness of their care. Helping the patient make sure they're up to date on any vaccinations that might be needed. And this is age specific. So working with primary care to make sure that that's up to date. Obviously, we also want to really encourage that the patient or their loved ones, even in their environment, abstain from tobacco use. And also from alcohol use. The combination together is particularly unsafe and has higher rates of recurrence. And so if we can take this opportunity to help a patient satiate from their tobacco or alcohol use, this ends up being a pivotal time to make those efforts and communicate to the providers that nicotine replacement therapy, whether that's a patch or a lozenge when appropriate, might be beneficial to help the patient quit tobacco use, would be very welcomed by any surgical provider. And then last, there's instructions on when the patient should be eating or have an empty stomach. And so the preoperative instructions that are given should be reviewed, and you can plan the diet accordingly. Oftentimes it's a clear liquid diet about 8 hours before the surgery. Sometimes if the patient is diabetic, they may have the patient on a full liquid diet for 24 hours before the surgery, and then clear liquids 8 hours before the surgery. There is some literature in using clear liquid carbohydrates. So this could be Boost Breeze or Ensure Clear. And then also there's thought about using something as simple as a Gatorade electrolyte drink that's a clear liquid before the surgery, because that sort of carb loading effect does have an impact on how patients handle anesthesia and recover. So there's some benefits to doing that as well. And always check with the surgeon to make sure that that's appropriate in this instance. Regarding the perioperative care phase, again, this is from surgery to discharge. So a lot of the recommendations here are really based on what is needed while they're in the hospital. So the first thing I would say is respect the visitation hours of your institution that your loved one is having surgery at. Oftentimes they're there for good reason, whether it's transition in the nursing staffing where they can carry the conversation and care coordination from shift changes. Interruptions in that process can lead to interruptions in patient care or adverse events. So respecting that time frame when the nurse handoff is occurring is really important. And then it also helps limit the number of interruptions in the care of your loved one. Being in the hospital is very challenging. It's noisy. Sometimes there's a neighbor in the room with you that has different care needs and can be very disruptive to your own. And staffing and nursing care needs throughout the hospital can be really challenging nationally. So I think respecting the visitation hours of the institution, while frustrating as that might be and wanting to be with your loved one as much as possible, it's also a good opportunity for you to take a break and step out for a minute, take a walk, stop by the cafeteria, or just get some fresh air. So use those opportunities as a way to take a little reset for yourself. I also think it's really important that you become a friend of nursing. They are there to support you and obviously your loved one. So having them on your side, whether it's just having a better understanding of what your loved one prefers in terms of, comforts of their home that can be recreated in the hospital setting as much as possible. If it's communication preferences, diet preferences, maybe how they want to communicate is really helpful to the nurses. They are friends, not foes. So definitely engage with the nurses and build those relationships so that it does truly support the care that your loved one needs in the hospital best. I always encourage active listening and learning. And that basically sometimes means not communicating. That might mean sitting with your loved one and listening to the information that's being given to them by the nursing or the physician staff throughout the day. Every specialist that comes through, whether it's the dietitian or the physical therapist, a lot of what they're doing in educating the patient, you can absorb as well as the loved one and be a part of that learning so you can carry that on when they are heading home. So I think just being a really good listener and active learner throughout the hospital setting can be really beneficial to you. Oftentimes the institutions will have the surgical team round early in the morning. This is usually done to help prepare the day for patients who are ready to go home. Typically patients are discharged before noon. So a lot of the activity throughout the day happens early in the morning. And again, with respect of shift changes and visitation hours, if you could have an early morning presence, that tends to be a really good time for you to be available to get that information and that knowledge about the plan of care. Of course, I always say trust the team. That goes back to the visitation hours and respecting shift change. And the hospital team is there to support your loved one and get them safely from the surgery home as much as possible. So I think just instilling a form of trust, even if that means that trust has been broken in the past, giving us an opportunity in any way to regain that trust, we would certainly encourage and be grateful for, because we know surgical transitions in the hospital stay is always a challenge. Rest. So your loved one needs rest, which is very hard in the hospital, but you need rest as well. So again, those breaks are very important for you to get a little bit of a recharge and make sure you're getting the rest you need. And then encourage your loved one to be a part of the active care. A lot of times there could be pain or there could be IVs or other tubing that can be really complicated in getting up and moving. So I think encouraging your loved one to do the care that's recommended in a very loving and supportive way can be very helpful to the team, because we definitely lean on the family to help encourage our patients to motivate them to get the best out of their visit and get ready to get home. The postoperative care phase also has many roles and important factors. The first that comes to mind is typically wound care. When related to surgery, there's often a wound, and that wound may need close attention and care. And this is where you get a crash course in nursing or wound care. On the inpatient side, or that perioperative care phase, that's when the nurses are coming in and doing the wound care. That's that active listening and learning. You're watching and seeing what they're doing, hearing the guidance that they're giving or being taught themselves, that you can can carry over when you go home with your loved one. Often there's instructions that should be given and reviewed at the time of discharge, so making that opportunity to be present for that phase, and then also asking questions and making sure you have an opportunity to demonstrate the wound care that might be needed so that you feel more competent and confident when you go home. Durable medical equipment, or DME, this is sometimes needed if a patient has any particular wound care or breathing apparatuses or feeding tube needs. This typically is set up at discharge, but the transition from the hospital to the home setting can be a challenge. So advocating for what your loved one needs, communicating to your surgical team after the hospital setting and letting them know what hasn't arrived that was discussed or is needing to be delivered, and then knowing the company, which again should be included in discharge information about where any medical equipment is being sent, is helpful for you to advocate and track down some of those things that are needed. Functional limitations usually are dependent on the type of surgery the patient has. This could be a wound in their leg or their arm that limits how they use that extremity. It could be limitation in bending their wrist, for example, having to wear a wrist brace to protect their arm from a surgical wound. It could be wearing a foot boot to help protect their foot from dropping after surgery. It could be needing to use a walker because maybe they're a bit weak from some weight loss or from being in the hospital for a period of time and being deconditioned or some loss of muscle mass. It could be limitations in how they move their neck or their jaw. So how they function is also a part of what makes the home environment safe, and the caregivers are very impactful in helping to monitor and be aware of that for the surgeon, since you know the home and that patient's care setting at home the best. Diet changes. This is a big one that, I think is something that can be prepared for in some ways. A lot of times after surgery, patients do have a limited diet, and it typically can be more of a soft or pureed diet, and looking for resources on recipes, asking family and friends who are offering to bring you meals, which again, you're going to say yes, thank you to, helping guide them to what type of foods that your loved one can best eat, and then understanding that there may be a period of time where that's not possible, and having other forms of nutrition like Boost or Premier Protein or other supplemental protein drinks. But hopefully a dietitian, if that surgery involves changes with eating and swallowing, is included in the hospital setting. Again, back to that active listening and learning when the dietitian comes, and then asking for a dietitian after surgery if one isn't already included in the care. And that goes back to the advocacy. Speech changes, of course, this is a very, very frustrating one for all. Sometimes your loved one has to write things down or use their hands to mimic, and that can be really, really frustrating on everyone when you just want to help each other, but understanding each other is a challenge. So patience, taking a deep breath, slowing down, keeping an environment that is without distractions and excessive noise, and making sure your loved one doesn't feel like they have to hurry or rush, and they can take their time to communicate their needs if their speech has changed in any way. And then your patience as a caregiver, and letting other forms of communication take place at various different times in their follow-up care. The other thing I like to mention is monitoring their mood. There's definitely an expectation that there's going to be a transition in how a patient feels from the surgical to the post-op setting. Sometimes, going into surgery, there's a little bit more of a fighting mental stance. And then after the surgery, there's a bit of a defeated mental stance, and helping the patient understand that that's normal and that this is a transition phase, giving them some positive and supportive feedback, but also recognizing that phase hopefully will pass. But if it is not, and it continues to progress where the patient exhibits, feelings of depression or sadness that is beyond what would be considered an expected period, maybe a few weeks to a month or so, or certainly if they have any drastic changes in their mood or behavior, are all very important things to communicate to the care team. And then just being an advocate and motivator to promote their activity, giving them opportunities to move about the house, encouraging that rather than being too sedentary, but also then giving them opportunities to rest. So short bursts of activity and then periods of rest rather than prolonged activity. So understanding that what your loved one might be able to do is much less than before, or less intense, less time. But encouraging that is still very important. And then I keep mentioning it again, that patient advocacy is the biggest role I find from a surgical perspective that the caregivers can have, because they really can move the patient in the right direction, but really move the system and their care providers in the right direction as well. Lastly, I'll mention transitioning care. This is going to be more specific to the times between those phases, the transitions from the pre-op to peri-op or the post-op to surveillance, because usually there are some key needs in those transitions that the caregiver can really help be mindful of. The first, as we talked about early on, is the dental care that's needed. If a patient is having radiation, it's really important that they have a dental exam before starting their radiation. And ideally, if any treatment is needed, also that treatment is given before radiation. Because if dental care is needed after radiation, there can be more complications related to that. And this is beyond dental care related to cleaning. This would be if a tooth needs to be removed or a patient needs a root canal. Those things really should be done before starting radiation. So the earliest that the patient can see a dentist and have their teeth examined before radiation is the best case scenario. It gives plenty of time to have that treatment done if needed. And then that segues into why this is so important is there's a time frame that's recommended from when a patient has surgery to when they start their radiation. So this time frame is about 6 weeks that the radiation should start after the surgery. So this gives time for the surgical sites to heal and the patient to recover properly, and then times for the care to be coordinated. So just keeping that in mind and helping advocate and facilitate the timely care is a huge role for the caregiver to support their loved one. So advocating for earlier consults with the radiation oncologist, even if that means you're not even sure that they need radiation yet, if that's a possibility, even if it's only going to be known after surgery when everything's done, there's still benefit in meeting with a radiation oncologist in the event that radiation is needed to help make sure that that timely care is done within that time frame. So being aware of that if radiation is discussed after surgery is helpful. Again, requesting a dietitian or a speech and language pathologist to be a part of the care after surgery and during treatment is really important. This helps optimize their overall nutrition, and that could be related to surgery. It could be related to radiation and chemotherapy. And then the speech and language pathologists are helpful in evaluating the swallowing function and the speech function of the patient and giving feedback on exercises that can be done to help prevent problems down the road, but also maintain function and help reduce any other complications or problems that can arise during treatment that might be able to be prevented ahead of time with just good education and knowing what to do to prevent problems with swallowing down throughout the treatment phase. This also includes lymphedema, which is swelling of lymphatic tissue after surgery and after radiation. The lymph nodes don't move the lymph in the body as well, and so that can cause some intermittent swelling. And so there's therapy for that, as well as physical therapy if there's neck stiffness or difficulty moving an arm or a shoulder or a hand or a wrist. Physical therapy can help with that. So just advocating and asking for those as part of the overall treatment package is really helpful. Some sites have a supportive oncology department, so this can be helpful if there are any concerns with the patient's mood or how they're coping with the treatments, or they just need more support or resources. And this also can carry over to how their loved ones are supported with resources or, the things they might need at home to care for their loved one. And then consider palliative care. Palliation means basically supporting and maintaining care. So sometimes there's concerns about the term palliative care as being end-of-life care, and that is not the case. It is supporting life care is how I think about it. So there's a role for palliative care at every phase of the treatment of your loved one, and it's a wonderful resource if you find that more symptom management or support is needed. So I encourage you to explore that with your providers so that it's a greater understanding of the benefit. In conclusion, a good laugh and a long sleep are the two best cures for anything. Caregiving the surgical patient is a big job with a lot of responsibility, and your surgical team recognizes that and wants to be a part of helping you build confidence and competency in doing that job and giving you the resources possible to help your loved one. So please speak up, advocate for yourself and for your loved one at every phase in their surgical treatment. And always make sure to make time for a good laugh and get some rest.
I'm delighted to introduce Dr. Shyam Rao, a distinguished professor in the Department of Radiation Oncology at UC Davis Health and a key member of the UC Davis Comprehensive Cancer Center. Dr. Rao is highly skilled in radiation therapy with a special expertise in treating head and neck and skin cancers. He's committed to advancing cancer treatment through research focused on improving outcomes and minimizing side effects, all while providing compassionate, patient-centered care. We're pleased to have him share his insights with us today.
Hello, my name is Shyam Rao. I'm a radiation oncologist who specializes in the treatment of head and neck cancers at the University of California, Davis. Radiation therapy for head and neck cancers typically involves daily treatments that are given Monday through Friday for 6 to 7 weeks. The radiation treatments are typically given by a machine called a linear accelerator, also known as a LINAC, and each daily treatment session or fraction can take 15 to 20 minutes. Treatment is typically given with the patient lying on their back on a table under an immobilization mask to make sure their head does not move and therefore ensure accuracy. There may be other treatment devices like mouth guards that are also used during treatment. Before starting treatment, the patient needs to undergo a planning session, also called a simulation, to fabricate the immobilization mask and also undergo a CT scan, which is used for radiation treatment planning. Any necessary dental work, specifically extractions of unsalvageable teeth, should be performed before this planning session. After determining which specific body regions need to be treated and the required dose, the radiation oncologist works with a clinical physicist and dosimetrist to determine the optimal beam arrangements to treat the targeted regions while avoiding normal tissues and aiming to minimize side effects. Beginning in week 1 and 2 of treatment, patients develop increasing dryness in their throat and mouth, as well as altered taste. In week 3 and 4, a skin reaction called radiation dermatitis develops, which is inflammation similar to a sunburn in appearance, as well as some hair loss in regions of skin that are treated with radiation. Also, in the 3rd and 4th week of radiation, patients develop mucositis, which is inflammation of the mucous membranes in the mouth and throat, which results in painful sores. Finally, in weeks 5 through 7, patients experience increased radiation dermatitis in the skin and mucositis, causing further pain. The radiation dermatitis and mucositis typically resolve within 6 to 7 weeks after completion of radiation treatments. While patients do not feel much during the treatment session itself, there can be numerous short-term side effects during the 6 to 7 week treatment course that are largely temporary. There are several keys to getting through head and neck radiation therapy well. First and foremost, we recommend maintaining good hydration and good nutrition. We specifically recommend a high-protein, high-calorie diet. In the beginning of treatment, patients often start with a solid, regular food diet, but have to transition to softer foods and then eventually a liquid diet. In some cases, patients may need a feeding tube to maintain good nutrition. A third important key is to maintain good oral hygiene. This involves regular brushing, as well as rinsing with either a saline or baking soda mixture, as recommended by a radiation oncologist. Often using a humidifier or oral hydrating products such as biotin or xylamelts may be useful. It is also important to maintain good skin care, which specifically involves using moisturizing lotion to manage the radiation dermatitis. In some cases, a topical steroid or a hydrocolloid dressing may be recommended by your radiation oncologist. It is also helpful to maintain good range of motion by doing specific head and neck exercises involving stretching of the neck, the tongue, the mouth, and swallowing exercises that can be recommended by your speech and language pathologist. As discussed before, there are many side effects that develop over the 6 to 7 week treatment course. Several of these can specifically interfere with our most important goals of hydration and nutrition. For the pain from radiation mucositis, medications such as lidocaine, a topical numbing medication, as well as Stronger narcotics or opioids such as morphine or oxycodone are often employed. If patients are receiving chemotherapy, there can often be the added problem of nausea and vomiting. These are often well managed with antiemetics such as Zofran or Compazine. Constipation can frequently develop as a side effect of narcotics, antiemetics, or, in some cases, poor hydration. This may require management with a stool softener or laxative, or a combination of both. Finally, altered taste can interfere with patients wanting to eat. However, it is important to remember that good nutrition and hydration are essential to getting through treatment well and recovering from the side effects as soon as possible. While treatment with radiation therapy for head and neck cancer can feel daunting, it is important to avoid interruptions in your treatment course as it can reduce the efficacy of therapy. For all of these reasons, it is important to ask others for help when needed so that you can complete your course of treatment. While the short-term course of radiation therapy can be stressful or even overwhelming, it is important to remember that patients recover and treatment serves the long-term goal of moving past cancer. While the focus of this talk has been on managing the short-term side effects of head and neck radiation therapy, we should also mention there are long-term potential side effects with treatment as well. These include, but are not limited to, dry mouth, which requires maintaining good hydration. Also, there is a higher risk of dental cavities potentially after radiation therapy, which requires maintaining good oral hygiene. Finally, we'll mention fibrosis, which refers to stiff muscles, which ideally can be prevented by performing routine range of motion exercises.
Today we have the privilege of hearing from Dr. Shiruyeh Schokrpur. His background includes groundbreaking research at the Buck Institute and his doctoral work at UCLA utilizing cutting-edge CRISPR technology. As a physician scientist and assistant professor at UC Davis specializing in solid tumor oncology, particularly head and neck cancers, Dr. Schokrpur is uniquely positioned to offer practical caregiving strategies informed by the latest medical understanding.
Hi everyone, my name is Dr. Shiruyeh Schokrpur. I'm a medical oncologist specializing in the treatment of head and neck and lung cancers at UC Davis Comprehensive Cancer Center. I'd like to thank all of you for joining us for this series on caregiving strategies for patients undergoing treatment for head and neck cancers. Today we will be discussing practical caregiving strategies with regards to systemic therapies used for the treatment of these patients. An introduction to systemic therapies. So systemic therapies for head and neck cancer can include modalities such as chemotherapy, immunotherapy, and targeted therapies. Chemotherapy is likely the modality that most patients and caregivers are most familiar with, as this has been a mainstay for treatment of cancer for a long time. Chemotherapies are aimed at destroying rapidly growing cells. Cancer is a disease of rapidly growing cells in the body when they should not be. Patients who undergo chemotherapy receive an infusion through a peripheral vein, typically, or through a port every week up to every 3 weeks during their treatment course. Side effects that are associated with chemotherapies include fatigue, nausea, appetite loss, constipation or diarrhea, mouth sores, skin rashes, hearing loss, and peripheral neuropathy. Each specific chemotherapy agent may have its own constellation of side effects, so it's important to review documentation provided by your healthcare team in order to know the specifics for the chemotherapy agent that your loved one will be treated with. The next type of systemic therapy is immunotherapy. The purpose of immunotherapy is to mobilize the immune system to attack a patient's cancer. Cancer, again, is a disease when cells of the body are growing when they should not be. And in fact, there are ways for the immune system to recognize these abnormally growing cells and potentially eliminate them. However, cancer is smart, and it has the ability to put up a "don't eat me" signal that inhibits the ability of the cancer to be defeated by the immune cells. However, we have developed monoclonal antibodies that are infused and can block this "don't eat me" signal, thereby unleashing the immune system's ability to clear the cancer. In a subset of patients, this form of treatment can work very effectively in clearing the body of the cancer cells. However, there are side effects associated with activation of the immune system against the body's normal tissues. Side effects to look out for include rash, diarrhea or colitis, endocrine abnormalities, pneumonitis, pericarditis or myocarditis, or neuropathy. In fact, any side effect that you can imagine could almost be caused by immunotherapies, so it's important to be very cognizant of any abnormalities or any feelings that are different than normal, and let the care teams know about it. Immunotherapies are typically administered every 3 to 6 weeks, but these side effects can appear anytime during the course of treatment, including within weeks or months after starting, or even it has been described years after starting the treatments. The final treatment modality I want to discuss today is targeted therapy. Although a smaller subset of patients are going to receive this type of therapy, head and neck patients are treated with targeted therapy, specifically those that target EGFR. These are monoclonal antibodies, again, that are infused through the veins. Patients may be treated up to weekly with this type of treatment. Notable side effects described for the treatment of these agents include skin rashes, nail changes, infusion-related reactions such as chills, fevers, or shortness of breath, electrolyte imbalances such as low magnesium, as well as very rarely interstitial lung disease. When it comes to all of these side effects, it's important to let us know as medical teams if anything seems to be going on that's out of the ordinary. We would rather err on the side of caution and be notified of a side effect that ultimately is not clinically meaningful, rather than wait on something that could be intervened upon before it gets too bad and impacts your loved one's quality of life as well as their clinical course and our ability to help them. The next topic that I want to discuss is the caregiver's role. Caregivers are an important part of the team that will help take care of your loved one, and they are very valuable in interfacing with the medical care team. Specific things that caregivers can do to help support their loved ones include driving to appointments, providing reminders on medication as well as nutrition, coordinating refills of medications, observing subtle changes in their loved ones, providing needed emotional support in order to lift the spirits while undergoing these arduous treatments, reducing stress associated with these treatments, and identifying early signs of complication, as I mentioned in the previous slide. All of these roles provide very important additions to help make sure that the care is being optimized for the patient and they are having the best possible ability to tolerate the treatment. Treatment can only help the patient if the patient receives it, and staying on top of these factors does help ensure that the patient can tolerate a treatment course. Specific interventions that can be done day to day to help support your loved one undergoing systemic therapy for their head and neck cancer include making sure that a patient has light, balanced meals if they're able to eat, or helping to support them if a G-tube is placed with the nutrition plan as advised by their medical team. Additionally, patients can get dehydrated with the treatment of head and neck cancer, and so reminding them to take fluids is very, very important, and supporting them for visits for hydration at our infusion centers. Assisting with household tasks such as laundry, shopping, or paperwork, providing emotional support with active listening for these patients without having the feeling that you need to fix the problem. Understanding that mood changes and fatigue are normal side effects from the treatment courses that we give, and being there to support patients as they go through the duration of their treatment regimen. And finally, encouraging patients to rest who often feel like they want to get up and be more active, but it's important to strike a perfect balance. And caregivers are good at being able to help us identify when a patient is overdoing it in terms of physical activity during their treatment. In the last minute or so, I want to talk about care for the caregiver. So you cannot support your loved one if you are not supported yourself. And it's important to take breaks without feeling guilty. Engage with our caregiver resources, such as today's program, as well as social workers, support groups, and counseling. Recruit help from family, friends, and respite care when you feel overwhelmed with the supportive role. And finally, recognizing signs of burnout, such as trouble sleeping, irritability, depression, and exhaustion. We truly value the caregivers who help support our patients and know that you guys are so important in making sure that we get the patients the treatment they need to help provide cures and prolong their lives in order to promote the best care possible.
I'd like to welcome fellow speech pathologist Ellen Berstein-Ellis, a leading voice in the field of aphasia and today's caregiver perspective. Her innovative work includes pioneering aphasia book clubs, collaborating with Yosemite National Park, and co-founding Aphasia Choirs Go Global. Ellen's journey as a caregiver for her late husband Steve, who faced salivary gland cancer with immense strength, adds another layer to her profound understanding and resilience.
Hi, I'm Ellen Berstein-Ellis, and I have the honor of being asked to represent the caregiver voice in today's webinar. I want to thank the Head and Neck Cancer Alliance for inviting me to participate in today's discussion. It's a topic I hold close to my heart, both professionally and personally. So let me jump into our story. Well, Steve and I were high school sweethearts. We were married about 38 years. Steve was a finance manager for a large phone company, and I am a speech language pathologist who's worked with adults with communication disorders. We have a daughter and son who were post-college at the time of his cancer treatment. Steve was diagnosed with a metastatic salivary gland cancer in July of 2018. It was a complex medical journey, and we received excellent care at Stanford Medical Center, and we're so grateful to those healthcare providers. There are so many different caregiving stories out there, and this is a complex looking graphic, but it drives home that there are multiple dynamic variables contributing to our experience as caregivers. This model, this cancer family caregiving experience model, highlights three interacting components: our context, the different contributors to the stress response, and the trajectory. I particularly wanted to point out the arrows at the bottom that describe two trajectories: the one of survivorship, those who return to a new normal, and that of bereavement, the path that we went down. Steve passed in July of 2019 after 1 year of treatment, but we had periods of being more on our own and not in active treatment, and that's the phase of the cancer experience we are focusing on today. Some of this may be highlighted by our other speakers, but I wanted this to be about more than just my caregiver experience, to honor the many different care partners' journeys, the many different care partner journeys. As a speech language pathologist, I'm trained to look at the research data. And frankly, I was surprised to find these statistics about caregivers and head and neck cancer. Depression and anxiety rates in head and neck cancer caregivers are greater than rates of caregivers of other cancer types. So head and neck cancer caregiver ranged from with significant psychological distress ranged from 20 to 57% compared to 13% in other cancers. Head and neck cancer caregivers often experienced higher psychological distress compared to the patients themselves. And there's an important discrepancy to point out. While almost up to 57% of spouses experience significant psychological distress 1 year after surgery, only about 16% sought mental health treatment. And yet we know that mental health can have a huge influence on recovery outcomes, and it's critical to address caregiver wellness alongside the patients. Researchers often suggested that the complex set of caregiving demands and the insufficient training may explain the high anxiety, depression, and fatigue experienced by head and neck cancer caregivers. So the side effect severity peaks at the end of treatment, just as care becomes home-based, increasing caregiver demands to manage complex care tasks, yet they often feel ill-prepared. Caregiver tasks may include tracheostomy care, pain management, wound dressings, management of drainage systems, feeding tubes, maintaining nutrition. It's a complex set of tasks, complex and demanding. Caregivers are essential to the head and neck cancer patient's support during and after treatment, so that value should not be underestimated. Yet there's no standard for evaluating head and neck cancer caregiver healthcare needs, and maybe there's not a standard across any cancer. But the good news here is that research is emerging to establish tools and interventions to address caregiver psychological and physical needs. But we need more. Weaver and colleagues offer that healthcare professionals should inform carers that their own well-being is as much of a priority as the patient's and encourage carers to access support. We all know that's a vital message, and we need to hear it probably multiple times, but it can be really hard to implement. So my goal was to validate your experience. You are not alone, and you are not the only one dealing with a variety of caregiver challenges. Focusing specifically on the post-treatment period, Matthews and colleagues looked at 15 qualitative studies that included the voice of caregivers through interview data. They then helped to develop 5 themes that framed the head and neck cancer caregiver story. Those themes included the emotional struggle, supporting nutrition, altered lifestyles, relationship challenges, and social needs. So around each theme, I've listed some of the key concepts, and then I bolded some that seem to come up across all of the different qualitative studies I reviewed. Let me describe a few of the prominent ones. Related to emotional struggle, protecting and shielding refers to the caregiver not sharing their worries and challenges out of concern of adding to the cancer patient's distress. Guilty eating, associated with supporting nutrition theme, described caregivers trying not to eat in front of their loved ones who are experiencing challenges with swallowing. Under relationship changes, loss of reciprocity acknowledges the significant change in relationship roles and balance, with the caregiver taking over many responsibilities for their partner. Take a moment and look over these different concepts. If you attend our follow-up live session, we'd like to hear which of these head and neck cancer impacts resonated with you as a caregiver. What else would you add? And perhaps what strategies have you found to meet these challenges? Well, let me share some of my lessons. Several studies suggested that being organized decreased caregiver stress. Find your system. So be an organized and proactive navigator across all stages of treatment. What works for you? Is it a notebook, a binder, or an electronic device? But you are the cog that helps to coordinate across multiple providers, and the organization really helped me to feel more in control. So as you leave active treatment, find out what to expect as symptoms peak, and ask if you can video any of your care training on your phone so you have it as a resource later on. Leaving active treatment is an important time to ask questions. So find out, feel empowered to ask about sensitive topics related to intimacy. Like I wasn't sure about caregiver safety related to chemo, and I needed to ask. Ask about exploring options for feeding formulas. There are an increasing variety of choices beyond the ones they used in the hospital. And just most of all, well, two things actually. Find out how to contact the healthcare team if unexpected symptoms pop up, because they really are likely to. And I know we experienced some doozies. So I was so glad to know how to reach back out to my team and get more information or help. And then finally, stay attuned to mental health needs of both the patient and the caregiver. Given those statistics I just talked about, I think it's really important to be aware of that. I think it's time when you're out of active treatment to start working towards maybe regaining relationship reciprocity, adapt to new ways of being together. Steve and I couldn't go out on the hikes we used to do, but we decided to listen to a meditation app, Headspace, and their series, Coping with Cancer. It's a mindfulness series. And we really got a lot of enjoyment out of just spending that time together and learning a new skill. And the mindfulness was a really great de-stressor. Think about a gentle reentry to social activities. Steve wasn't ready at first for all the maybe larger social types of things that we had done in the past, but he was willing to go to a humor night at a local cancer support community. I want to recommend looking into these communities. There's 196 of them, and they offer free services, free programming, free classes, free counseling, and they're just a wonderful resource for both, and I should mention for both caregivers and for the patients with cancer. So it's a really whole family focused organization. I found that it was really important to cope with changes in communication and oral care. So as a caregiver, I could optimize the environment, reduce noise, make sure I had a pad of paper available for Steve, use other modalities like texting or writing when talking was painful or just not successful. I learned to be the MacGyver of toothbrushes by finding lots of small micro toothbrushes to help with Steve's oral care. I also learned to adjust social visits to not center only on food. I learned not to invite visitors just for meals because Steve couldn't participate. So instead, we found other activities that were less stressful and more enjoyable, like games and cards and movies. And we just shifted our focus when we had people visit. As you leave active treatment, make sure your care plan feels manageable. We felt stressed sometimes by the amount of time Steve had to spend doing his PT exercises, his trismus stretching exercises, his speech exercises, his feeding trials, his feeding times. And we really wanted to be compliant, but we also needed to adjust the intensity so we could have some fun too. Your providers may not realize what other providers have assigned, so just speak up and try to find a manageable plan. And if you are on the bereavement trajectory like we were, this next one is important. When we were told there were no more viable treatment options and initiated hospice care, Steve let his boss know he would not be returning to the job he loved. They decided to keep the retirement date that was set a few weeks down the road, but he passed several days before that date. And although Steve rarely missed anything that had to do with numbers. He just didn't know that I'd lose half of his pension if he died before he retired. So I know that pensions don't apply to everybody these days by any means, but if you are still working and you have a pension, please call your HR or your pension manager and ask, will I lose a percentage of the pension payment if not retired at time of death, even if fully vested? I think it's something that not everybody's aware of, and it's just important to ask that question and then make decisions that make sense for you and your family. I think this is a great time when you're leaving active treatment to increase the focus on meeting caregiver needs. So perhaps if you haven't had a chance yet, see if there's a local head and neck cancer support group that meets either in person or online. I just want to really advocate for the magic and power of support groups. They can help you feel less isolated. They can help you gain new perspective, increase a sense of social support. There are so many positives to support groups. And if a support group isn't available or just isn't a comfort place for you, then maybe perhaps consider some of the peer-to-peer mentors that are available for head and neck cancer. And I'll share some resources in just a moment. But most of all, give yourself lots of grace. You are doing a really hard job. So both of these wonderful consumer focused organizations offer support groups and one-to-one peer mentors for both the patient and the caregiver. So both the Head and Neck Cancer Alliance peer-to-peer program and the Support for People with Oral Head, Neck, and Cancer also has a peer-to-peer group. So take advantage of a trained volunteer or consider joining their program and pay it forward. It's a meaningful connection. I want to give a shout out to these excellent past webinars by the Head and Neck Cancer Alliance. I watched them all in preparation for this presentation, and I highly recommend them. And watch for the upcoming sessions in this webinar series focused on a variety of pertinent topics, including nutrition and intimacy. Allison was on 2 of the Head and Neck Cancer Alliance past webinars, and I was just really impressed with her own caregiving website, The Negative Space. Now that refers to an art term and not a mindset. She has partnered with another caregiver, Justin Baima, to produce the In Sickness podcast to tackle a wide variety of caregiver topics. These are both great caregiver resources. Rosalind Carter aptly said, and just emphasized how important and prevalent the caregiver role is with this quote. There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. I don't think we can underestimate the importance and value and prevalence of caregiving. You can see Steve making a sign language "I love you" hand over his shoulder. I'm so grateful we took a trip to his beloved ocean, despite needing to bring his IV pole to hang his pump and his food. I hope that you will all find those important moments of connection and meaning, whatever trajectory path you are on as you leave active treatment. Thank you again for letting me share my caregiver journey with all of you.
Thank you for joining us today for this important topic. If you have any questions, feel free to reach out to us via email at connect@headandneck.org or visit our website for more details, www.headandneck.org. We hope that you'll join us next week for our online discussion, where you will have a chance to chat with other caregivers and professionals about these important topics. It's an honor to connect with you. Wishing you strength and peace in the week ahead.